Morning, Bex. Right, fantastic. So we're at 10 o'clock, so we will get started. So very good morning to you all, and many thanks for joining. My name's Laura Boyd, and I'm Director of Digital Partnerships at Health Innovation Yorkshire and Humber. And we're one of 15 health innovation networks across the country, really set up to think about how can we accelerate innovation into practice for greater patient, public, but also NHS colleagues benefit. And this series has been launched as a series of sessions, really thinking about how can we use digital and AI to deliver on the commitments set out in the 10-year plan. To date, we've held a couple of sessions on ambient voice technology. We can share the recordings if people are interested and have missed that. And this one really follows that same approach, thinking about how can we use digital and AI technologies to meet the needs and the requirements of neighbourhood health. So if we move to the next slide, just to get us started, we do have a kind of a bit of an audience participation. So questions for you, if you could scan the code and input thoughts and answers either now or as we are going through the webinar. So what digitally would make the biggest difference in neighbourhood health? Just give people a moment or so to scan that QR code, and then we will run through the agenda. But just to say, we will be recording today's session and we'll share the recording out later. We also plan to do a write-up of the sessions, but we won't ascribe what people have said to individuals. We will just write up the themes about what we have heard today. And we hope that this will form a bit of a kind of a wider series of write-ups. Our next session will look at the single patient record and the NHS app, and there'll be a link shared with you at the end as to how to register for that. And then we have a further session planned in May to look at automation. But if there are areas that you'd be particularly keen to hear about, really thinking about how can we use digital and AI to drive those commitments set out in the 10-year plan, please do let us know. Now, one of the reasons we wanted to kind of start the new year with neighbourhood health is, for us, it really embodies those 3 shifts set out by the government as they came in. So this is really around how do we move care from hospital into the community? How do we ensure that care is driven and centred around the individual and the patient? And how do we move that kind of proactive care upstream so that we're really focusing on prevention? Now, at Health Innovation Yorkshire and Humber, we've got a real focus on identifying the needs and the challenges, and then thinking about how digital and innovation can solve some of those challenges. So the structure of these sessions is quite formulaic now. So we generally invite a national and a regional speaker to set out the kind of the policy commitments and the challenges. We invite local case studies, and in this case, individuals working and leading some of the neighbourhood health hubs to talk about their experiences on the ground. And then we like to provide a platform for some of the great innovations who are meeting some of the kind of the challenges within digital health. And there'll be a chance to hear from 5 or 6 of them after the break at 12 o'clock today. So hopefully a really interesting session for everyone. The innovators we've invited fall under 3 themes, which Minal Bakai set before Christmas in meeting some of the challenges in how we deliver neighbourhood health. So we've got innovators who are looking at operational integration across different NHS and voluntary sector and other providers. We've got innovators who are looking at proactive case finding and proactive identification of people living with multiple long-term conditions. And then we've got 2 to 3 innovators who are looking at supporting people self-manage and manage their conditions within their homes. So hopefully people have now had an opportunity to scan the QR code, and we'll probably flash that up later. But if we move to the next slide, I'm just going to talk through the agenda. Now, unfortunately, with this being the time of year that it is, we've had a few challenges with our agenda today. So there's been a bereavement, there's been some sickness, and there's been a kind of an urgent request for a trip to Holland. So I'm afraid Minal Bakai has sent her apologies and is unable to join today, but she has asked the fantastic Leah Ali to take her place. And so Leah works in the NHS England team, both on the NHS app programme, but she also sits on the data and digital programme board for Neighbourhood Health. As you can see from here, Leah is a consultant psychiatrist and clinical advisor, but she's also has a clinical academic role and is looking at studying the kind of biopsychosocial model of care. And for those of you who've heard Minal speak before, she really talks about that approach as being central to Neighbourhood Health. So we're really sad that we don't have Minal today, but absolutely delighted that Leah is able to join and share those insights. But because of timings, we haven't made the agenda flow quite as we'd hoped. So Leah can join us at 11. So it's slightly kind of in between some of the case studies that we're going to hear from. We will be hearing from the fantastic AC first. He has two roles and will introduce himself, but both is a non-exec director at West Yorkshire ICB, but is also Dean of Digital Health at the University of Leeds. So will give us a fantastic scene set. Because Neighbourhood Health spans many different sectors, I'm really delighted that we've got Mark from the British Red Cross who'll be talking about their work supporting high-intensity users of A&E and secondary care services, and the work they're doing to support individuals stay well at home. And then we've got examples from individuals working on Neighbourhood Health. To have. We've then got Melanie and Natalie from Wakefield, and they will all be joined by Amy, who is working in North East Lincolnshire. Now, what is really vital to us at Health Innovation Yorkshire and Humber is really understanding why we're here. And so we're going to start with a patient perspective. Anika is a primary school teacher in Wakefield, so cannot be physically here because she's teaching her students, but she's kindly pre-recorded a video about her experiences of the multiple long-term conditions she's currently living with. So I'm going to ask Luke to play that video. So a huge thank you to Anik for taking the time to record that video. And we wanted to play that really to kind of highlight the experiences of individuals living with multiple long-term conditions and what really matters to them, because I think at the heart of it, that's what neighbourhood health is all about. So we're going to pass on now to AC. I'll let him introduce himself. AC, do you have some slides and would you like us to stop sharing so you can share your end?
Morning, Laura. No, thanks. I think I'll just speak without slides. That might be useful just to give an scene setting, because I can see that you already have loads of slides. So it would be useful to see the screen and colleagues. Thanks, Laura, for the invitation. And I think it's great to see this event series starting off. It was great to work with you in sort of thinking and conceiving and helping shape the series. I think what you just heard from Anika is a very powerful story, and perhaps the suitable scene setting for why we are here today. What I wanted to sort of reflect on is why the three shifts, and sort of one of the key aspects of those three shifts was highlighted by Anika in terms of early diagnosis and early pickup and prevention sort of effectively, which then leads, if we delay that, leads to significant, I think, costs, but more importantly, poorer outcomes within the community. And I think I would like to refer here with the work that Colonel Farrer did in terms of looking at the distribution across segments of populations, where a significant amount of activity is within acute trusts and secondary care. So what you heard perhaps with that example earlier is a significant deterioration of experience and potential outcomes, but also costs. And then as a result of those high costs in picking up disease later on, the challenge is managing an overall cost envelope in terms of medication, care, and support so far. So I think that gives a good indication. And again, that same report by Cardinal Farrar also highlights the opportunity spaces, specifically across CVD. Just 37% of CVD patients have cholesterol. About 28% people with type 2 diabetes only have optimal HB1AC sort of treatments. 73% of those with CKD stage 3 and 5 treated optimally. So that you just sort of heard an example there. And stage 1 and 2 are almost ignored. And this is based on sort of data and is published publicly accessible through Cardinal Farrar website as well. Just 6% of eligible dementia patients are receiving any treatment. So there's a huge opportunity space which has driven this sort of desire for these three shifts effectively on how we move to prevention, importantly, how can we sort of shift from analog to digital. I think as this was happening in some of the ICBs and across ICSs, we were starting to think about moving to community anyway. So even before sort of integrated neighborhood teams and care as a concept was absolutely systemized. So here at West Yorkshire, we have been thinking it for some time and making sort of people, process, technology, and moving into community a key sort of ambition for us to improve outcomes. Our collaborative health and social care with BCAC's work was always strong. We had a set of multidisciplinary teams tailored to local needs, and we were in the process of moving to proactive and preventative community care, where care is delivered in community venues for better access, but also, more importantly, reduces crisis and unplanned hospital use. This all very absolutely chimes with the direction that now with the NHS 10-year plan as well as new strategic commissioning intent is coming out. We have been sort of, since the last 12 months, we have made some concerted efforts here as well. About 4 to 4.5 million has been sort of invested from West Yorkshire's point of view to accelerate integrated neighbourhood sort of development. We have set sort of technology funds to look at innovative tools, focus on things like fall prevention, increased maturity of digital infrastructure like shared care record for seamless sort of journey management, better data use, insight-driven proactive care using sort of business intelligence data, people's voices being central to neighborhood sort of health, where how you can bringing sort of patient public voices in sort of enhancing patient engagement. We are also lucky to be part of the wider national sort of neighborhood health implementation pilots. We have 3 of those pilots in West Yorkshire, and you will be hearing from our colleagues Mel and Natalie later in the program in terms of what we have been doing in those pilots and learning and sharing our experiences across the country. But while we were looking at all of these dynamics, and this is where I think working closely with Health Innovation Yorkshire as well as other health tech partners, clearly we didn't want to let the opportunity go in terms of the sudden exploration and of AI tools. I was at Stanford about a couple of years back and for a digital health conference, and firsthand saw a generative AI tool being tested at that stage. So this is 2023 March, and I'm talking about, and it was Hippocratic AI. So this was looking at generative AI models to support sort of care in the community for sort of pre-ops, for follow-ups. So there was a range of opportunities that was laid, and that gave me a lot of insight and ideas in terms of what we should be doing to improve our digital maturity in the region and start integrating AI tools. Fortunately, we had a lot of colleagues in the region, including Laura and Health Innovation Yorkshire colleagues, who have helped to string this series of events for us to look at specifically AI tools built on digital tools that can help us expedite those 3 shifts. In the region itself, I've mentioned Hippocratic AI. We have sort of innovations like coming out of the university, like AdSilico, which is looking at generative AI technology specifically around virtual patient populations, looking at high fidelity simulation ready sort of populations, scalable and bespoke sort of virtual patients for tailoring specific sort of research needs as well as clinical needs for clinical trials. Then we have the opportunity also to look at sort of multiple pathways. Diabetes was mentioned, for example, on how we can use wearables, third-party apps, get and sort of AI-driven centralized engine for self-management using sort of automated guidance suggestions. But more importantly, how can we then enact that personalized interactions with the care team locally within places and integrated neighborhood teams, where the clinical workforce, the wider health workforce and the community services can come together to provide a much more superior patient experience. So what you could hear in that patient voice and the patient example there, so much more could have been done in community before it been picked up as a superior care experience in hospital. So I think there is so much, there are so many and so much opportunities for us to learn and scale up that this event series becomes compelling, specifically starting with AI and neighborhood health. I can also see at least a couple of examples that or initiatives that you've brought in, and I'm particularly following an example from southwest of England, I think using Brave AI, where a lot of GP practices are now running super clinics, so-called super clinics over weekends, picking up patient profiles who would typically, so this would be things like COPD, perhaps stage 1 and stage 2 patients where wait times would be much longer, and eventually help us to reduce admissions but improve outcomes, equally manage costs, which can then be reinvested in various areas like medication management and enhanced offer of support from commissioning perspective. So I think the opportunity space is huge. Of course, those pilots are ongoing, and it will be useful to then learn from those pilots, hear from those sort of evaluations, and inform our own local implementation plans. So I'm really looking forward to this event series, Laura, and I'm great for pulling this together. I'm keen to attend all of them, but hope you have a great day today, and looking forward to some of the outcomes and specifically the write-up in terms of how we can integrate some of the learnings within West Yorkshire, but more importantly within the region, and then share our story as well. Thank you.
Wonderful. Thank you so much for your time. And you highlighted Brave AI, and they will be speaking later today, which is fantastic. And it's great to hear of the research coming out of the university, because any way we can bring that to life, I think will, be so valuable. So huge thank you. Right, I'm going to now ask Mark to join the stage. Mark's from the British Red Cross and is going to talk about their work in terms of supporting high intensity users of secondary care. So thanks, Mark.
Thank you, Laura. Hello, everyone. Apologies, my colleague Rachel's not well today, and Rachel is the manager for our HIU services in the north of England and Isle of Man. So is the expert, and I am going to do my best to relate the information across and answer any questions that you may have. So before I get into this, which is a reminder of the services that we offer, British Red Cross are one of the largest providers of HIU services in the UK. You may be familiar with the numbers that about 1% of attenders at A&E suck up about 16% of resources, costing billions of pounds. The model that we operate is aligned with the NHS England model for HIU services. And I'll take you through a little bit about the programme that we run, and then at the end start thinking about some of the potential opportunities for predictive modelling, utilising data and innovation in the future. Because as you will see from the next few slides, much of what we do at the moment is based on NHS data, patient attending data, so it's historic, and it's after the fact. It's after people have attended a number of times and utilised a lot of the resources already, and we're trying to stop that continuing. But if we could get in front of that and prevent it happening in the first place, that would be perfect. But we're not there yet, but it's where I think we need to get to. So next slide, please. Just as a brief introduction about who we are, we've been high intensity usage is HIU. I think there's a question there. We've been around supporting the NHS since it was established as a trusted partner. We have a national infrastructure that supports us in everything we do, from safeguarding, psychosocial support, effective training for the people that we employ to support all of our services. And we're very focused on health equality and improving access to care and removing some of the barriers. Next slide, please. So in terms of the national contacts, as I said, it's nationally endorsed by NHS England. Directly to improve the quality of life for the people that are impacted by this particular service. We've been running it for the past 5 years, and we're focused on improving the quality of life for people who come into the HIU service. It supports better outcomes for individuals in the community, in neighbourhoods. It reduces the utilisation of unscheduled care and can be both an intervention for when people have already reached crisis point or as a preventative solution. So some of the people coming into this service, or many of the people coming into this service, come in with non-medical issues but social issues, and that's why it's important to use this assertive outreach to support them. Next slide, please. So it's not a surprise that when we look at the number of people attending ED 5 or more times in the year, which is the map on the left-hand side, the darker red is the more time people attend A&E, is very much aligned with the deprivation levels within society. So where we've got higher levels of deprivation, we've got higher levels of people attending A&E. And so it's directly correlated to the index of multiple deprivation. Next slide, please. So why do people, what triggers frequent attendance to A&E? So it can be a number of reasons, people with multiple morbidities, loneliness, mental health, substance abuse, housing and insecurity, and poverty and deprivation. Many times it doesn't involve a medical issue, and it's a social issue. And sometimes people can be turning up at A&E every day for a week because they're lonely, or they've had a bereavement. Their partner of many years may have died, and they just need somebody to talk to. And so it's a really important service to A, take the pressure off ED, but B, support people who are going through a difficult time. Next slide, please. So this is just an overview of the programme. I'm not going to go into detail on the slide, but it'll be in the pack, I'm sure, that we send out afterwards, so you can see a bit more about the reason for it, what the service entails, and the impact that we have on the system and the individual, which are both important. Next slide, please. So some of the key principles of the HRU service is that it's about the person and their objectives, what their issues are, and helping them to create goals, support them to live independently in their own homes. It's demedicalised, so we consider the person's holistic needs and seek to understand the root causes for their high intensity use. It's not punitive. We don't criticise them for doing what they're doing, but we try and help them and understand where and link them to other services that might be able to support them better than their ED department, including referring them in primary care network and their GPs, which we all know there is pressure in those areas as well. We build into multi-agency networks, so across the VCSC networks, housing support, alcohol services, mental health. And it's about resilience, building resilience of the individual, not reliance on other people. So helping them navigate their own lives through their complex health and social care environment. So it's removing barriers and facilitating access to the support that they need. Next slide, please. So the service principles for the HRU programme is it's data-led, as I said earlier. It's about how many times people have attended A&E. And when we pull the data from our NHS partners, we look at somebody who has attended A&E at least 5 times in the last 12 months and at least 3 times in the last 3 months. That's where we get our data from. And then we assertively outreach to those individuals to get consent for the support. We try to reduce emergency admissions. We liaise with psychiatric or mental health admissions. And we minimise ambulance conveyancing and GP visits. So it's one-on-one casework. As I said, it's demedicalised and it supports self-management and has an element of health coaching, and all the caseworkers are trained health coaches. It's holistic, person-centred, so improve access to care coordinate, identify unmet social needs, and reconnect with individuals with family, friends, purpose, and community. Next slide, please. So what impact does it have? Well, next slide, please. Our target is aligned with the model, which is for the individual, improve well-being, health activation, control of their lives, financial stability, housing and environment, social value and service satisfaction. So we monitor and understand the impact we have on the individual. But more importantly, or as important, is the system savings. So we aim to reduce A&E attendances by 40%, reduce admissions to hospitals by 40%, and reduce conveyancing by ambulances by 40%. And we target ourselves to achieve a 412% or £4.12 return for every pound invested in the programme. Next slide, please. And for the individual, what we aim to do is, as I said earlier, is improve their own personal experiences. So increased activation levels, say they were treated with dignity and respect, focus on more community-based support, and help them become more confident about their own health and well-being. and we monitor that for every individual we work with. Next slide, please. This is the latest performance data for East Riding. Within Yorkshire and Humber, we have 3 services live, one in Sheffield, one in East Riding, one new service in North Lincolnshire, and in the north, in my patch, we also have services in Stockport and Newcastle upon Tyne. But the very latest data for the year ending December 25, we managed to reduce attendances in A&E for the cohorts that we worked with by 65%, admissions to hospital by 66%, and conveyancing by 61%, giving an overall cost saving of £548,000, or a return on investment £3 spent of £5.06. So we've managed to achieve our targets on that particular front. Thank you. Next slide, please. I'm okay for time, aren't I? I'm rattling through this. It's a little bit quicker than I expected. So this is probably the most important next slide for this particular audience, because what could the future look like? What should the future look like? How can we get in front of the issue as opposed to dealing with individuals after the fact who have already cost the system thousands of pounds because they haven't been supported in the way they need to be supported. So if we could utilise, yes, they do face-to-face. It's all assertive outreach, face-to-face casework with individuals, and the caseworkers do up to 45 people per year. That's the maximum, which again is aligned to the model. In some areas, in Newcastle upon Tyne, for example, we're focused on drug and alcohol abuse, and that number of referrals has had to come down because of the risks associated for the teams, and we have to double up in some situations and send 2 caseworkers out. So we've had to take down the target in a way, and they also have a balanced casework. So we don't work with all the most complex cases. We work with complex, medium and low complexity to ensure that they can achieve maximum potential and not burn out. If we put one individual on 45 complex cases, they wouldn't last very long with us. So we have to make sure we work with a balanced caseload. So the future, we believe, and this is very early days, is the use of AI predictive modelling that may be able to help prevent HIU in the future by analysing the behaviours and profiles of existing patients. So this is data analysis. It's not my bag, but it's the way that we can look at past cases, analyse profiles, analyse reasons for attending hospital, analyse issues in their lives. And an example of that is bereavement, as I mentioned earlier. When a partner has lived with their partner for 30, 40 years and one partner suddenly dies, that individual is completely isolated and is looking for support and can end up in ED to get that support. So if we can use that as a trigger for a potential HIU person and get in front of it before it happens, then that might be a way for us to start prevention of HIU rather than dealing with it after the fact. So that's what the second box says, utilising extensive patient data within all areas of the system, NHS, PCN, 111 service and ambulance service could help us. So I missed that question. I'll come to it after I've finished here. Could potentially identify the conditions, not health conditions, but the conditions that could trigger HIU patients. So potentially drug and alcohol, bereavement, other things that we won't know until we analyse that data, what those potential conditions for future HIU cases could be. And then pilot that, test it with people, because it's going to be challenging for a service to assertively outreach to somebody who hasn't done anything yet, to say that we think that they may need some support. They may not need support, but they may need support. We might be just in time, or we might be barking up the wrong tree, but we don't know until we've started to analyse the data. So as I say in the last box, if we can identify future HIU patients early, the potential cost to the system by prevention of access before it happens could be exponentially higher. Because if you think at the moment, we are looking at patients who have already been to A&E at least 5 times in the last 12 months and 3 times in the last month. But if we get to them 12 months earlier, we not only save the money that would cost us before we find them, but we also save the costing moving forward. So prevention of crisis and multiple attendance can be even more financially beneficial to the system, but more importantly, it's more beneficial to the individual. If we can get to them before they reach crisis point, then it's a far better outcome for everybody. So I just saw a question in the chat. I'll try and answer. Yes, we look at both physical issues and mental health issues when we are looking at the data. So we will know what we are dealing with when we talk to the individuals. But yes, yeah, absolutely, and that's the challenge: single records and sharing of data, and this is why this is an ambition rather than a reality at the moment. But this is why I'm here talking to you guys about health innovation. The challenges we face in some systems, like Manchester, for example. We had a service in Manchester, but the information governance wouldn't share the data with us, the patient data. We couldn't run the program. So, you know, we have to be open about why we need the data, because it's there to help people and to save money. We can't allow the red tape and the restrictions when it is important for patient care, but it's also important for the NHS and the budgets, because we're not going to get tons more money to run more and more services. We need to be more efficient about what we do. And so sharing of data between PCN networks, between ambulance services, between hospitals is critical. So we've got the full picture about the individual, and it's about their care. So we have a justification for doing it because it's to support people. So I can't emphasize enough how much the data is important, both for delivering this particular service, but also for finding a future for prevention in the neighbourhood. That's what the 10-year plan is all about. Make sure they don't even reach the front door, get to them before they're at the front door, know your patient and support them in the way that they need. And 9 times out of 10 in this particular service, it isn't clinical, it isn't medical, it's social. And any other questions? Of maybe one other. Sorry, Sean, have I asked that one? Do we have data to show the sustained impact of the HIU interventions, or is there a requirement to maintain or deliver reduced support forever? I think the answer to that question is we support individuals for between 6 to 12 months, but we don't, when we discharge them, we don't, we give them our contact details. So if they have a relapse, then they have the ability to get back in touch with their caseworker. We monitor, we've been doing this for 5 years, and we monitor as much of the data as we can to determine the impact, the long-term impact that we're having in the service that we're providing. So the answer to that is we hope that the work that we do in the majority of cases means that they now have the appropriate connections and don't need to attend A&E for non-medical issues. Clearly, if they have a medical issue, we encourage them to go to A&E because that's important. But if it's a non-medical issue, we hope that they have the skills and the resilience to find alternative support in the community.
Mark, Exeter has her hand up. Would you like
yes,
to?
Sorry. Yes. Hello.
Oh, hi.
Exeter.
Thanks
Hi.
very much, Mark. This is I have heard about your work, and I'm literally across the river in northeast Lincolnshire, and I've been meaning to touch base with you. It sounds great, and we're trying to do something similar, but it's not quite working for us yet because we haven't worked out how to identify the right people. We've been trying to use the PHM, the HNY PHM tool, but it doesn't seem to be picking up the right people for us. So my question is, how are you specifically identifying these groups of people? Whose data are you looking at?
So we're just starting a new service at Scunthorpe, which is right next door, I think, isn't it? You're in Grimsby, yeah?
Yeah.
Yeah, and but the data that it might be a good thing to take offline and chat about separately, but just as a quick overview, when we work with our NHS partners, we basically tell them everything we need on the data feed. So we'll say we want the age, the name, the number of times they've attended A&E in the last 12 months and the last 3 months, the reason they presented. And so Rachel, my colleague, who is the expert, will have will send through to their data people the information that they need on a monthly basis. And then when we get the data, we then start reviewing the patients and selecting them based on that balanced case load that I was talking about. So they'll look at the very complex people, they'll look at the reasons for presenting, they'll look at the number of times that they've attended. And so I can, if you'd like to reach out after the call, happy to have a chat with you and maybe bring Rachel in to show you how we get to the data we need.
Oh yeah, that'd be great. Thank you.
No problem. Just getting back to Sean now, does people not presenting for routine services, e.g. vaccination, health checks, feature in ranking people? No, it doesn't at the moment. It's that could be something that we build into prevention, people not showing up for things. But at the moment, we're just looking at the data that I explained a moment ago. I wasn't aware of the service until we held a number of MDTs for some, this is Paul Lang, number of MDTs for some really complex patients who are high intensity users and causing significant challenges for health and social care partners. Input and support from the Red Cross has been really helpful in supporting to the wider system and the individual patient. In my experience, the knowledge of the patient that the Red Cross brings to their contacts has helped us to look for solutions that reduce the service appropriately. Thank you. That isn't a question, but it's a compliment, so thank you very much. Is this type of HIU service typically commissioned across Yorkshire, Humber and England? Yes, but not enough. There's a massive opportunity, and all I will say at this point is we try to make it as efficient as possible. We demonstrate the return on investment. Many trusts see this as a social prescribing activity or a PCN. The people attending PCN are not the people attending ED. A lot of the times they're attending ED because they can't get into PCN, but the frequent attenders at PCNs are a different cohort because we've looked at the data to the frequent attenders. So if a trust is or an ICB is saying, oh, we've got HIU covered because the PCN network's got a few social prescribers in there, you're not fixing your HIU issue. You've got to fix it at the ED. And that's where you're going to save the most money. There are 72 ED departments in the north of England and Isle of Man. We've got 5 services, so that's the opportunity. So spread the word, give them my number. I'm happy to talk to anybody, and we can do what we can with whatever funds we can achieve. So we'll be delighted to have another conversation. Your premise is that the system always offers a solution. Surely sometimes it does not, and ever presents as part of the problem, e.g. long waiting times for elective surgery? I'm not sure I understand that question, Michael. Do you want to ask it me do you want to explain it a little bit more?
Can you hear me?
Yes, I can hear you. Hi.
Yeah, even, not ever.
Oh, sorry.
Well, yeah, that having identified somebody to work on, the premise is that there is that the health and the social services and everything and voluntary sector presents a solution that can improve the situation. But I find that somewhat surprising, and especially sometimes the system is the cause of the problem, e.g. long waiting lists, somebody in pain, for surgery. What do you do in those circumstances?
Well, as I explained, we select people on the lists who we believe fall into the category that we can support. So I'm not denying that you're absolutely right, that a lot of attendances in A&E can be caused by long waiting lists, cancellation of operations, that type of thing, but that would be classified as a medical issue, and we're trying to focus on the complex psychosocial needs of individuals that shouldn't really be in A&E.
Do you have any data on the people who do present medically? I mean, people who feel they haven't been diagnosed appropriately is another example. What would you do there?
Well, we are looking, when we get the data, we are looking at the ones that are appropriate for our service. We haven't at this point got a way other than reporting back to the hospital to say this individual is attending ED for medical reasons. Is this on somebody's radar? We can do that, but our service is commissioned not to fix waiting lists or fix the problems with elective surgeries. Our service is commissioned to support people in the community who are attending A&E erroneously. Does that make sense?
Do you have any rough data what that proportion is? Is it 10% or?
I don't. I'm sorry.
I'm going to draw this section to a close. With Michael, I'm sure we can follow up separately. A huge thanks to Mark. It's been absolutely fascinating to hear about how you're taking that very data-driven approach to cohort patients and then put in place, a solution and support in the community. I'm hoping you'll stay to join the panel session later this morning. So if there's more burning questions, we will bring them up there. So huge thank you to Mark. I'm now going to invite Anna, who's going to talk about the work at the City Healthcare Partnership. So Anna, I'm hoping you're there and we've got your slides ready for you.
Yeah, thanks very much. Thanks for inviting me today. So I was just going to talk about kind of frailty and digital and neighbourhood health. Apologies for people who might have heard some of this. We'll do a whistle-stop tour of kind of what we're delivering and then how we're using different digital tools as enablers for this. So I'm a consultant geriatrician, work out of the Dean Bishop Integrated Care Centre in Hull, which is a specialist centre delivering care in the community for people living with frailty. So just on the next slide, please. We're covering all of Hull and East Riding and delivering both kind of proactive care for people living with moderate and severe frailty and then reactive elements. So I'll just go through our model really, really briefly so that you can then understand how we're using the digital tools. So the next slide, please. We opened in 2018 with very much a focus of things that are aligned to now the 10-year plan. So trying to shift more kind of specialist care into the community, shift to from kind of reactive urgent crisis management to more proactive care. So hopefully had a load of experience over the last few years, which we're more than happy to share in more detail if people want to get in touch. The next slide, please. So in terms of the proactive care, what we've tried to do is deliver the best evidence base for people living with frailty in terms of how to care for them well. And so that is delivering what we call comprehensive geriatric assessment. So it's kind of an MDT approach where we try to identify needs across physical health, mental health, social care, functional care, and then also offer kind of care support as well. And then have an assessment of those needs, interventions, and organise the appropriate follow-up and ongoing coordination of care. Obviously, to do that, we need to case identify, and so we used population health tool called Electronic Frailty Index, and then case finding across all of health and social care. Obviously, there's new tools coming in which can augment this now, things like Brave AI that I'll understand you're going to hear about later on. So we try to do the holistic assessment and interventions, and then follow up. So we do that in terms of across Hull and East Riding in two different ways. So if we just look at the next slide, it just shows the kind of different neighbourhood approaches within this. So Hull is city deprived, and it's being split into 3 neighbourhoods. So we've been delivering this proactive approach across the whole city. So kind of, I guess, sitting above what will be the neighbourhood teams. So obviously advantages to that in terms you've got a specialist team across the whole city, but not necessarily the more in-depth kind of local knowledge within neighbourhoods. And when we have our MDTs in the afternoon, because it's patients could be coming that we've seen that day from any of the kind of 25 practices across the city. We're not able to link in specifically for then discussions within the primary care, PCN or neighbourhood teams. So we do kind of written communication back to them. But for East Riding, because of the way kind of it's structured, so we've got the DP practices, PCNs, neighbourhoods, much more kind of locality based. There's much more single practice PCNs and neighbourhoods, so particularly on the coast, so that the green one's there, and the kind of pinky one, Holderness. So what we've done is when we've done our proactive models, we do a day of the week for each of those. So, and then the benefit of that is that we've been able to then in the afternoons when we're doing our MDTs, link in with the practices so we can get their social prescribers dialing in and the locality social workers. The other difference that we have across Hull and East Riding is that predominantly for Hull, people come to our centre in East Hull for kind of face-to-face assessments in terms of these MOTs that we deliver. Whereas in East Riding, we just have one member of the team goes to the person in their own home and the rest of the team dial in. So been using like Microsoft Teams to facilitate that, and that just helps with a bit of efficiency. And we're not, got the whole team kind of travelling around all of East Riding, kind of end to end. It's 1,000 square metres that we're covering. So just move on to the next slide. In terms of the reactive care, again, we're covering all of Hull and East Riding, but kind of based from Hull and then kind of spoken out. And that's for delivering the urgent community response and then the hospital at home services for frail people. And so the digital tools that we've been using have been really important in enabling us to deliver this at scale. If you just look at the next slide, I'll just go through these in a bit more detail. So I've talked about how we've used what we call kind of virtual CGA, so just one member of the team in the person's home. We're using AI scribing for these assessments. So So from a medical point of view, the assessments could be, over an hour on average for each individual patient, and then normally that would have been another 30 to 40 minutes writing all of that up. So the AI scribing tool has given us a lot more efficiencies in terms of the documentation in particular, and we've used that then to kind of increase the number of assessments that we're delivering on sim days, but then also use the increased capacity that we have on other days. We're reducing capacity on a couple of days a month to deliver kind of internal team training. So that's how we've tried to kind of use one of that tool to help support the team. In terms of in particular, I think the urgent community response and the virtual ward, the hospital at home, we're using remote monitoring. So we've been using BioBeat. Obviously, there's other devices available. So it's a chest monitor, which we can get kind of 5 days usually in terms of the battery life. And that means we can see single lead ECGs, so useful to get kind of an immediate 24-hour tape essentially. But it also does blood pressure monitoring, SATs, respiratory rate and temperature. So we don't sit and monitor them in real time. We just check the dashboard a couple of times a day. So we let people know they're not being live monitored, as it were. If they feel unwell, they still need to kind of phone for help in the usual ways, but really useful in terms of reducing some face-to-face visits, but enhancing kind of the medical care that we can offer in terms of earlier titration of medications and things like that. There's a wrist watch as well, which they're obviously reusable in a way that the chest leads aren't, but you can't get the single lead ECG, so advantages and disadvantages to both. And then the remote examination kit, so we use Ty2Care. That's been really useful for us in terms of how we use our workforce across the whole of the patch. So for the kind of proactive comprehensive geriatric assessments, we have, it's often a therapy assistant who's gone into the patient's home, so they can be delivering equipment that's needed and things like that, and then it's the medical and pharmacy team dialing in to do the consultations. But they've got this equipment so that if we need to listen to somebody's chest, they can do that there and then. It just requires us logging onto a slightly different dashboard, but you can control it. It's a really good high definition camera, so you can see skin problems much more easily than just on kind of Microsoft Teams. There's a tongue depressor, so you can get a good look in people's mouths, and there's even an oroscope. So again, just examining, ears, if there's wax causing hearing impairment, things like that. So again, saving, traveling time for clinicians, and then potentially follow up face-to-face visits as well using that kind of equipment. Or also use it as a kind of training tool. So if we've got paramedics, nurses that we're kind of upskilling in clinical examination, they can take out this equipment, examine people remotely. We can listen in from our base, or they can record them and bring them back, and so you can listen back in kind of a supervision style as well. So that's been really important in kind of upskilling our workforce. And it also means for our reactive team, we can use our support workers as well as our paramedics and nurses who have been trained in assessment. So if they're going out to do blood tests, bladder scans, ECGs, those kind of things, but then they're concerned about somebody, we can get them examined using this equipment and a video call in real time rather than having to send out somebody else. So been really good enablers for us covering a large geographical area. So on the next slide, I just wanted to touch on outcomes, I guess. So from a kind of proactive review, we know that the kind of CGA model works for people living with frailty. So if we're targeting kind of neighbourhood interventions, we know that frail people are high intensity users of services, and if we can shift to a more proactive approach, we know that we'll get system benefits and individual patient benefits that are highlighted there. So on the next slide, please. So across Humber, North Yorkshire, ICB, this is kind of model that we're trying to promote in terms of the evidence-based interventions for people at different stages of frailty, and what might work. And so when we're developing different neighbourhood teams, I was trying to make sure that everything's aligning to these kind of principles. And obviously there's different, all the emerging digital tools are hopefully going to enable us in this, and particularly I think things like Brave AI potentially in the future, thinking about how we can subsegment and target our resources. So the next slide, please. So I guess, you know, slightly thinking forward in terms of how neighbourhood teams are going to be aligned. Obviously, kind of specialist teams doing kind of hub and spoke things out into neighbourhoods, or being neighbourhood based. Some of the AI tools can help us break down the cohorts and identify which groups are going to benefit the most, and potentially then segment and target how we get specialists into the different MDTs. You just wanted to highlight a really useful resource. It's just that one page being produced by the British Geriatric Society and endorsed by the RCGP, which is trying to identify the kind of key groups that would benefit from different approaches. So building on the core 20+5, but specifically, sorry, for older people, and it's got outcome metrics there. And then I guess I tried to create, using ChatGPT, this model of you know, how neighbourhoods interface with place, ICP and regions. I'm not very good graphically, so I thought I'd use ChatGPT to try to generate this. But my first attempt with this, exactly the same prompt as what generated this, so just to highlight the kind of problems and fallacies, generated an image which was a fairy in a forest with a unicorn. So I do not understand how it got there, but yeah, we got there in the end. I don't know what I did wrong the first time. I think I'll leave it there. Happy to take questions, and I'll be on the panel as well if needed.
Fantastic, thank you so much, Anna. You really brought to life, you know, the power and the value of digital and remote monitoring tools compared to the huge geographical region that you're supporting. So it's absolutely fantastic to see that in practice. We are running slightly over, so we won't take questions now if that's okay, but we'll wait for the panel discussion. So I'm now delighted to welcome Leah Ali, who's kindly stepped in to cover the session that Minal was going to talk to. I know, Leah, you've got your own slides to share, so we'll stop sharing, and if okay for you, we'll hand over to you now.
There, I'm just getting my slides up. Thank you, and I'm sorry I'm not Manal, first of all, and I'm sorry we had to. Thank you very much for reading the time. Give me 2 seconds. Let me just see if I can get my slides up. I did test this before, but can all probably see yourselves now. Can you see that?
Not yet, no.
Laura, I might have to ask, have you got the document that I sent you? I don't know why it's not showing.
Yes, we do.
Would it be all right if you got that up?
Yeah, of course. I'm just opening it up.
Just while you're doing that, I'll introduce myself. But thank you very much for inviting me. As I said, I am sorry, I'm not Manal Bakai. So I work with Manal on the National Neighbourhood Programme, specifically the Digital and Data Steering Group. And I'm a consultant psychiatrist. I work in the South London and Maudsley, and I also work as a clinical advisor in the Transformation Directorate. And I have been involved in neighbourhood programmes and everything else that they've been called in the past for quite some time now, pretty much my whole career. And one of the reasons that Manal put me on the Digital and Data Steering Group is precisely because I have experience of setting up different types of integrated care, neighbourhood model services, both frontline in the NHS, in industry, in various formats, particularly with digital component. And also it's sort of comes into my portfolio of things that I advise on in NHS England. So I sit on the NHS App Senior Leadership Team. I have the Shared Care Record Programme as one of the 2 clinical advisors in my portfolio, and I've worked on a bunch of other things like digital therapeutic strategy in the national channels and a whole bunch of other things that all have a relationship to neighbourhood. So first question that Laura said that you're going to want to know is, what is neighbourhood? So I've basically got some, sorry, that is, I could have the next slide. Yeah, thank you. I've got some notes from now really around this. And essentially neighbourhood, as I'm sure some of you already know, it's a large scale change programme. It is very definitely not claiming to be anything new. This is the next iteration of what many of us have tried to do, just stay on this one for a sec, of what many of us have tried to do over many years now, of trying to design care that goes across organisational silos and that is really properly centred around patients. But I think one of the reasons that I was so excited to be asked to help with this is because this is the most positive I've certainly been in my career, that there is real commitment on multiple different levels to actually achieving this kind of transformational change. And I'm really glad that you've all met today, and I'm really sorry that I can't stay. I would really love to stay. The programme looks great, because I think it is this kind of range of things that, especially in the digital arena, that are really going to make the difference. So Neighbourhood is a large-scale change programme. It does aim to do both the hard and the soft changes that are required. The hard things include aspects around funding, infrastructure, the policy and the governance arrangements that are needed to enable neighbourhood models. And it really is the importance of all of that change management part, which I know that you all probably know very well, about rethinking exactly how delivery models work and getting that mindset and cultural shift, particularly around the biopsychosocial model, which I'll come back to in a moment. So what is our practical focus? It is thinking about what those enablers are, understanding what data and digital capability looks like, and also down to things like estates, workforce training and development, and taking a population level approach. So the national programme is divided up into these 4 steering groups that work on each of these different areas. And as I said, I sit on the digital and data steering group, so I have the most knowledge of what's going on in that arena. The target cohort is people with long-term conditions who are at rising risk of escalation and who have this problem around multimorbidity, and where there is significant psychosocial need, which plays in very much to why I have this involvement, because this is absolutely where my core clinical skill and expertise sits. Could I have the next slide, please? So the other answer to the question, what is neighbourhood, is actually it's about a biopsychosocial model of care. And I'm just conscious that not everyone will be familiar with that. I suspect a lot of you are working in that way or trying to make that shift, but might not necessarily know this terminology. So what I would just like to do very briefly is just to kind of introduce you to where it comes from. So it actually comes from Engels in 1977, who described this idea that our health experience is actually informed by things that are in our biological sphere, things that are in our psychological sphere, and in our social context. So it's taking this full holistic approach. And we can get a little bit philosophical if you like. We talk in my world, very much in mental health world, about the problem of the mind-body split, which can be traced philosophically to Descartes, saying, I think, therefore I am. So there's implication that there is a difference between your mind and your body, and that these things have to be treated separately. But we know that's not the way people exist. That's not how they have any of their health experiences. And actually, it's about the organising principle of their lives. And if I'm going to go for philosophical statements, I tend to go for that one that's in tiny writing right on the left-hand side, which comes from a Roman playwright called Terence, which suggests that I am human, nothing inhuman is alien to me, which is really the whole of somebody's context is important when we're thinking about how to address their health experience. What has this got to do with digital, I hear you ask? I will come on to this in just a moment. Could I have the next slide, please? So just a very practical example, and very deliberately not a mental health example, of what does biopsychosocial model mean. This is a slide I use quite a lot when I'm teaching. around this, including either clinically or in kind of policy strategy spheres as well. So if you take someone with rheumatoid arthritis, they have all those different factors that's probably in tiny writing on your screens around these different aspects of their biological, psychological and social context that relates to their rheumatoid arthritis. The same chemicals that are floating around in their joints, destroying their joints, actually are also implicated in the biological theory of depression and anxiety. And we know from the evidence base that 30 to 40% of the people with rheumatoid arthritis also have a diagnosable depression or anxiety. And this is probably related to this biological component about the actual cytotoxic chemicals, but also the psychological and the social components. We know that pain itself is a hugely psychological phenomena, and that there are many different factors that affect how your pain will express itself, even in the context of a physical health disease, an autoimmune disease like rheumatoid arthritis. We know that there is a very different presentation for symptoms depending on your social context. What is the stress, exacerbated by your job? Are you a concert pianist, or are you someone where you may be able to cope longer with the stiffness and swelling that's in your fingers, and how that relates to your whole experience? And we tend to teach this by getting people to think about biological, psychological, social factors and where they appear in someone's health journey. And this becomes really important when you start to think about digital enablers of this whole model. And that's why I want to bring it up on today's meeting. Could I have the next slide, please? So just to illustrate that a little bit more, and particularly in the context of digital, the case study on the left-hand side of the screen actually comes from some original patient-held record work that we did at South London and Maudsley. So there's this really terrifying statistic for people with severe mental illness, which is that they lose 20 years of their life compared to the average person in the population. And that's not from things like suicide, that's from things like physical health mortality. So that's speaking to this biopsychosocial model of health experience. There are all these factors interplaying that come in these hard outcomes for people. So we worked with a group of patients who had severe mental illness. So these are diagnoses like bipolar affective disorder, schizophrenia, and other severe mental illnesses. And we worked with them at a time when they were quite well in their sort of illness experience. And it was particularly, this was actually sponsored out of the Service Users Research Academic Group. So it was very much around, what can we do to empower patients in the therapeutic relationship? The contention being actually that most of our health system is very medicalized, back to that mind-body split that I was talking about. That's what a medicalized model speaks to, is the predominance of the physical health model. And that actually it's very paternalistic. It's very geared towards the power in the relationship being with the clinician and with the system, not with the patient. And when you're trying to build neighbourhood models, that's one of the key things we need to be able to tackle, is how do you actually address that relationship? And we don't just say that for because it sounds nice and it makes everyone feel happy that we're trying to make things patient-centered. It's because we have a really good evidence base that says that when we do that properly, we get really good outcomes in people's long-term conditions, so actually their health outcomes. And we also optimize system KPIs. We reduced A&E attendance and attendance GP surgeries, outpatient appointments. So it's a win-win. You're getting wins for the patient on their health outcomes. You're getting wins for the system around system KPIs. And that rheumatoid arthritis example that I had before actually comes from work that we did at King's Health Partners, sponsored by the academic institution, across 160 outpatient service. It was called Imparts, where we built biopsychosocial models around physical health conditions, including in the rheumatology clinic, and doing things like surfacing that 30 to 40% of people with a comorbid rheumatoid arthritis and a mental health diagnosis, but then also putting in the digital and the service enablers that actually meant that they got a full biopsychosocial formulation and they got a management plan that was geared around that. And when we did that, we actually take rheumatoid arthritis in particular, we reduced all of their health outcomes, improved their health outcomes on pain, stiffness, swelling, etc. And we also reduce the amount of disease-modifying drugs. These are the big, heavy medications with serious side effects, have to be highly monitored. Reduced prescription of disease-modifying drugs, as well as I was saying about the impact on system KPIs. People had less relapses, so there were less A&E attendances, less attendances at outpatient clinics. So win-wins. This would cost 160 outpatient services, everything from dermatology clinics to teenage and young people's cancer. And part of the kind of key enablers, there were things like, I used to run the education arm of that. So you would have people coming in doing outcome measurement, doing that digitally. So things delivered on iPads, but then integrated into the workflow so that we were then giving decision support. And I hope I'm building a picture for you of why thinking of that, the system in a more connected way, both the digital components and what you're trying to do clinically and the underlying clinical model, we're trying to do all those shifts. We have to think really carefully how digital can enable those big shifts. And that is really what my kind of thing that I bang on about, especially when I'm on the steering group or when I visit places, is actually about this, is what are the digital enablers? What is that digital data environment that's going to enable this shift to a biopsychosocial model of care? And with this patient B, who's a 66-year-old gentleman with bipolar affective disorder. He'd been under detention under the Mental Health Act, so had his human rights taken away at least 3-4 times. So he'd always been dragged forcibly to hospital before. Really, really coercive relationship with health services. We started working with him. He had patient health record. He was monitoring his mood, which he wasn't that interested in, but he was interested in measuring his blood pressure with a Wi-Fi enabled blood pressure cuff. And what was kind of key about that was because this was underpinned by health psychology principles and proper behaviour change, he actually gained agency, which we were measuring with things like the patient activation measure, which meant that he was able to take control of his own healthcare. He saw that his blood pressure was going up, so he made an appointment for his GP. This is astounding. Like, for somebody who has only ever been dragged to hospital, like properly dragged by the police to hospital before, this was somebody who, of his own volition, went and made an appointment with his GP. And while he was there, not only did he get his high blood pressure treated, he also decided to show the GP his mood scoring, which showed that he was starting to become manic. His mood was going up, which meant the GP had a key moment in time to work with this person and say, maybe we just do a lithium level check, which was the mood stabilizing drug that he was on, which was out of sync. And the reason it was out of sync was probably to do with his kidney function, which was probably related also to his high blood pressure. So these things are connected, and meant that he could have his drug dosage optimized, which meant stabilization of his mood. That meant quite probably a change in his pattern. He previously would have gone high, come off his medication because he didn't feel like he needed it, because he felt so good in himself, and then he would crash and be at huge risk to himself, and then he would end up in hospital under detention. So you're talking about really big outcomes with actually relatively low cost interventions, but thinking carefully about how that digital ecosystem, done sensitively and with a knowledge of what people's health experience actually consists of, and doing that in an evidence-based way, you've got the opportunity to build these great outcomes. And actually, this slide was actually one I prepared for when we were developing the digital therapeutic strategy in the national channel, so integrating apps into the NHS app and into .uk, this was sort of 2 years ago when we were looking at MSK and mental health conditions in particular. And one of the things it talked about was needing to have these two sets of foundations. So you've already heard me talk about the biopsychosocial model and a bit about behaviour change. And I haven't got time today, but more than happy to kind of talk about this at length, and interested to hear people's experience of using these principles. Things like logic of care, really thinking about health inequalities like we did with people with severe mental illness dying earlier than other people. And this evidence-based piece around supported self-management, which is that bit that I was saying to you about long-term conditions, proper improvement of patient agency in a health psychology focused way, leads to those outcomes both for the patient and system KPIs. And the other one is this digital clinical services approach. Could I have the next slide, please? So what I've seen quite a lot, both in my national job and in my industry jobs as well, and a bit in frontline in NHS, is that we often treat our digital infrastructure as in a very technology-led way. And we don't think about it as a channel in the same way that we think about a hospital or a clinic or how we build clinical services. And so one of the things that I've done quite a lot in my own work, particularly on the industry side or on the research side, is trying to build these digital services, really thinking about them in the way that we build clinical services, thinking about all those factors. That's all they are in the middle. They're literally the things when we're, building a business case for a clinical service, like I did for my own neuropsychiatry service in Croydon and the various ones I've done before, is thinking about that and applying that to how we think about digital services. And for me, I think the most successful digital programs around neighbourhood are going to be the ones that really get this, the ones where you get that integration across. You're going to need to find your collaborators, find those change agents who are you're able to put together your thinking, your understanding of, your local population, those different disease pathways, the particular factors that are affecting those populations, and put that together with a really good understanding of how clinical services work to be able to try and produce that transformation. Can I have the next slide, please? Okay, so actually, I didn't have another slide that I wanted to show you particularly now, but what I did want to come back to was some of Manal's insights that she'd handed over to me from when she's been doing her visits around the country, and particularly around digital transformation. So very clearly, two key priorities are emerging, and I'm sure this is something that's happening in your own region. Data sharing being a really key one, as being able to enable that neighbourhood shift, and the second one is digital operational integration, being different to single patient record, but actually more about workflow and how we actually do that. So you might think of that in a kind of in a limited way, in terms of or not limited way, in this initial phase as integrated neighbourhood teams, how they're going to actually do that work. But it does come into this wider vision for neighbourhood as we start to get that relationship working across all providers in a system. How do you start to get that really patient-centred, person-centred, because your VCSE sector, your non-health sectors are absolutely key here for that full biopsychosocial model shift, is how do you start to get that workflow integration? So those are the things that Manal wanted me to pass on to you. And she also wanted me to say that she's really hoping that people are going to be ambitious with this, and that you are really try and push the boundaries around how you think about this, and right down to things like having ambition around your procurement vision and those sorts of things. That was all I had to share with you. I'm very happy to take questions, and I'm really keen. I genuinely am really sad that I can't stay for the whole day. So I'm really keen to hear about other people's experience and will answer anything that I can.
Fantastic. Thank you so much. And what a powerful patient story to really bring to life, the power of true neighbourhood working. I really love the call to be ambitious. I really like the way that you positioned, find your collaborators to work across multiple sectors to make this happen. Huge thank you. Now, there's a couple of questions, I think, in the chat, so we'll start with them because we've got a few minutes. So Stuart Smith, do you want to come off microphone? I'll come on microphone and ask a question out loud.
Yeah, hi there, hopefully you can hear me. Yeah, so we're an SME that's working within a number of health and wellbeing technology areas. So we're doing some research with a couple of universities at the moment around using computer vision to optimise physical balance. What's been really interesting about the project is it's become more of a neurological element, and actually the links between the neurology, the brain protecting certain areas of the body has been really interesting. But scaling the project and getting access to clinical research resource and funding is quite expensive for an SME. So what advice, Dr. Ali, could you give an SME and other innovators such as ours on how we can work with clinicians, access funding, and scale these types of projects?
Well, I think actually that's probably not a question for me to answer. That's probably more a question for Laura to answer, actually, because I think this is where institutions like the HINs are going to be really key in building those partnerships. Is that fair to say, Laura? I think that's
Absolutely. You know, we're here to support, so please do get in touch, and we can either now or, you know, a separate session run through the range of support that's available to help with to help innovators, because I do recognise the challenges set out.
Yeah, and I think, Stuart, I would say the key bits that we're looking at from a national perspective, you know, so this initial piece with the 43 sites is really, we're really geared around places that have got the beginnings of those relationships. So starting with the relationships across the providers, but actually is also the relationships with the market, actually, and being able to, you know, the HINs, etc., are going to be really key in how that is facilitated, because it's really important that we get those outcomes quickly. There's been loads of attempts to do this before. As I said at the beginning, Neighbourhood is not trying to be something new. This is not trying to be something new. But in order to really kind of deliver on that ambition, we are going to have to get those partnerships working in a way where we focus on what that evidence needs to look like and how we do that scaling. Because I've worked with lots of, you know, SMEs, Stuart. I've worked in-house with them, and I've worked with them in my NHS role, like your Stuart. And it's always the same thing, isn't it? You get to one stage with the pilot, and we can't really. It's very difficult to get that vision translated across the system so that we can actually realise that benefit in a meaningful way. And for me, the neighbourhood community, and what I'm told is that there will be, some of you may have heard about it already. In fact, some of you may have heard about the expressions of interest that have gone out to neighbourhood sites. Is anybody aware of those? Would be good to see how many people are kind of aware of those. But I think it's really important for the digital community to lean in quite hard around this, because it'll be you guys in all your different roles understanding what that digital transformation needs to look like in order to be able to achieve those outcomes. And so it's really, really important that when those initiatives come out, that you're in those conversations and that you're finding the right levers to be able to do that. There is supposed to be a digital community of practice being set up. That is just starting now. So it will start with the EOIs, is what I'm told.
Excellent. And hopefully we've got time for just one more question. So Russell talks about the issue of trust. So given the unknown factors driving the disparity in outcomes for ethnic minorities, how would trust be built?
So I'm a really big fan of taking a design-led approach. So I have a design background. I'm actually doing design research this week, which is sorry, that's why I had to change the timings around a bit. And I think I think there are more opportunities that we've got to use existing design research methodology, particularly around inclusive design, to really tackle inequalities. So that is literally what we did in that example that I showed you. It was geared around understanding there are particular needs of that disadvantaged group. And I've seen quite often that you get the kind of sidelining of health inequalities, but it's front and center of neighbourhood. It is very clearly articulated that this has to be about addressing health inequalities. We know the non-health the social determinants of health are massive. 80% affects all of those long-term conditions, affects that cohort, that target group. The things that are going to get purchased and do well, we know we've got a really good evidence base that says you've got to take the right approach to that inclusive design approach. One of the ways we've done that in previous work that I've done, say the MSK one, is we try and combine the academic approach, so actually understanding what the evidence base tells us around particular challenges for people with different types of disability or from different minority groups, actually taking an evidence-based approach to that and mapping that to the kind of traditional way that either service design or product design is done, and mapping that to those user research. And you come out with something that's much more powerful. With my commercial hat on, my industry hat on, it's usually cheaper to deliver, and you get much more quickly to outcomes. So that's normally what I've advised in any of the startups that I worked with before. It's for me, it's win-win, because the system is getting the benefits that they want. And you're also getting to that return on investment quite quickly.
Fantastic. A virtual massive round of applause, Leah. Really appreciate your time, and it's just brilliant to hear the energy with which you brought to the session. So a huge thank you. Assuming okay, we will circulate the slides that you shared.
Yeah,
so
that's
thank
fine.
you.
Well, I might just check them because I had a whole load of extra ones in there, Laura, before you circulate. That's all right. Thank you so much. I would love to keep the relationship up, and I really genuinely am sorry that I can't stay. I would have loved to have heard the rest of the programme, but thank you very much for having me.
Thanks, Leah. I'm now going to invite Mel and Natalie from West Yorkshire ICB to talk about their work on neighbourhood health. Have we got Mel and Natalie?
Can you hear me?
Yes, we can. Yeah.
Brilliant. And I need to apologise because Dr. Ali and I didn't share our slides together, so I'll be mindful of not duplicating some of the information that you're going to see from us around what we're doing across West Yorkshire Integrated Care Board. So for colleagues, I'll just introduce myself. My name's Melanie Brown. I'm the West Yorkshire lead for our chair of our West Yorkshire Neighbourhood Health Board, and we'll talk about some of the mobilisation because our West Yorkshire ICB has 3 of our places that are part of the National Neighbourhood Health Implementation Programme, which you've just heard from Dr. Ali. And I'm just checking, Laura, you popping the slides on the screen for us now. Well, thank you, Natalie, for doing that. So I'll be very mindful of not duplicating what you've just heard a moment ago from Dr. Ali. But what we've signed up to as a board is our commitment to deliver neighbourhood health in its fullest sense as a major priority for our West Yorkshire population. So when we're looking at how we develop our integrated neighbourhood teams and the digital tools they need to be a success, we're also looking at that from a perspective of what do our general practices need to be fully enabled in terms of the digital tools and having access to shared care records, for example. What does that mean when we're taking care of people in the community, when people need access to urgent neighbourhood health services? So we're doing this work not just for our MDTs and our integrated neighbourhood teams that are working on a small geography level, but also across all of the 6 components of neighbourhood health. And we've given ourselves some metrics which are on the right hand side to work towards. Some of them you'll recognise, which are really important from a national political perspective about how do we evidence the reduction in unplanned admissions, but also we need to have absolute focus, stellar focus on reducing health inequalities and supporting our wider system and in terms of improving outcomes for our population. And we know that through working on projects with local authority, with DWP, with some of our mayoral combined authorities, we've got, we can do some of this through improving work and work on listeners too, as well through an economic accelerator programme that we're working on across West Yorkshire too. So I just want to say we've got some wider outcomes that we're working towards, which are described on the right hand side. If I just move on to the next slide, if that's all right. So for us, at the heart of this is what would this feel like, which is different for our population across West Yorkshire. And people will be familiar of I statements that voluntary sector organisations, 10, 15 years ago asked us to develop in any transformation work that we're doing. So these are our I statements for the population of West Yorkshire around the 6 components in neighbourhood health. So for each of our service users, our population, our patients, this is what we would like them to see would be different in terms of their experience of care around the range of the 6 components. So, for modern general practice, we'd want our service users to recognise that they can see their GP as part of a team and that helps them keep well, prevents them from ill health, and make sure that there is someone else who's connecting with other community services to support the individual patient's needs. I won't read out all of them, but we'll share this slide, but we just want to make sure that we're highlighting today that we're framing this on what really makes sense and is important for individuals, and it's important to keep that in mind. So for us, we are building on some work that we have with our Yorkshire and Humber shared care record, which I know everyone on this call will be very familiar with, and many of you will be working on that big transformation programme. And our aim and our ambition is that our shared care record will ensure that we've got digital integration to make sure we've got real-time information sharing and joined up decision making. We want to make sure that we're able to mobilise our aligned population health data, so we're targeting the interventions and the resources for our patients where they're most needed most, and that's come from our data tools that we've got, our BI data warehouses, and we're able to really evidence and segment our populations to drive forward those interventions. Ultimately, you've heard some of this from Dr. Ali, so I won't repeat it, but it's all about driving forward our person-centred care, delivering that at a neighbourhood level, making sure our MDTs are working across general practice, community mental health and social care. So in West Yorkshire, we're investing in a number of digital tools to support us, making sure we have cross-organisational clinical information sharing, and we're going to do that through the shared care record across Yorkshire and Humber that we've all got access to. I know we're all working through what does that look like in our local area. We're making sure that we promote the citizen enablement through the NHS app, and we know that there's digital poverty issues that we do need to work through together to make sure that everyone has access to these digital tools. So that does come up. We know we get that in at our local review scrutiny committees about how are we working together across the system to increase opportunities for people to access these digital tools. So I just wanted to highlight that. I know that I'm sure that's on a lot of people's agenda. And then we want to make sure, that our proactive support is in place, and that we can evidence that by having digital tools that is like shared care plans and doing that digitally rather than through any other approach and format. So there's some of our ambitions. I'll move on to the next slide if I can. So what are we doing in reality? We in West Yorkshire, we invested 4.1 million of some resources which are called service development funding for this financial year, and that's helped us do a whole range of things, but we've just got a few pictures here that are linked to digital solutions. So we're doing some falls prevention work, and we're using digital tools to help us target individuals that we know are potentially at risk of falling, and we can do some proactive modelling to identify those people at risk. We're equally doing some falls work and using digital technology to buy enabled care kits for people with moderate to severe frailty, and that helps us respond more quickly. We're piloting that now at the moment. It was a 70k investment for Leeds, but obviously if that works, then we'll scale that up across West Yorkshire. So just to be aware, we're also looking at case finding in Calderdale. That's another area that working really hard on neighbourhood health agenda, and we're trying to identify people at risk much earlier on in the process through a structured case finding approach. And then, as you've heard from Dr. Ali, the whole premise of what we're doing around neighbourhood health is to have that early intervention, better management of long-term conditions for our neighbourhood health models. Natalie is going to talk you through a little bit more about our significant investment around Yorkshire Humber care records. I won't repeat what Natalie's going to say later on slides. We've also been testing out in Leeds care. We've got a Leeds care record that we've been underway with for some time. You'll be very familiar with this. We've been looking at how we can digitise respect forms and making sure that end-of-life care is responsive by sharing information across multiple clinical systems. So that's some of the work that we're doing at the moment practically. I'll just move on to the next slide if I can. So in Wakefield, we've been using AI to help us in an innovative way, and we've been doing a lot of work about this, and it's got quite a bit of attention. So we've got our data warehouse, and we're using those principles now to create a West Yorkshire-wide data consolidated service, and work's underway on that. But through the Wakefield data warehouse system we've got currently, we've looked at AI modelling to help us predict hospitalisation of some of our priority patient cohorts. And we've done this through combining our patient data from multiple sources and developing a comprehensive risk model. And we've included those data inputs, and we've looked at what our clinicians have deemed relevant in terms of high risk areas and backed up by clinical evidence. Just want to highlight that too. So we've tested various machine learning models to establish our baseline performance in Wakefield, and then we've used the tool to select and refine features and fine-tune data, and we've done some critical thinking and constructive challenge on the tool as it's been developed. And what that helps us do is be able to it's been able to give us some really positive outcomes so that we can absolutely enable, through using artificial intelligence, we can use our modelling to predict the likelihood of hospital admissions. We've got an 86 to 94% accuracy for our priority cohorts, and there's been a lot of, there's nothing particularly fancy about the way we've done this, but there's been a lot of critical thinking about how we've applied this, and then we've been testing our assumptions with the cohorts of patients that we're then putting in interventions and target interventions to support their outcomes. So to be honest, we've done a lot of work around our data warehouse to refine and link the data, making sure then that we are putting the right interventions to support those patients. So yeah, I mean, to be quite honest, I have to say a lot of experienced data scientists have been working on this with business intelligence leads to be able to test this out, and we're willing to sort of share the approach and methodology with anyone who is of interest to that. But just wanted to share how we're really trying to embrace the AI tools that we've got to think differently in the way that we cohort our patients and target them with appropriate interventions. So I hope that's helpful. I'm going to hand over to Natalie, and she's going to take us through some of the exciting work that we're doing to mobilise and make the best use we can of our Yorkshire Humber care record. I'll just hand over to Natalie now, if that's all right, Laura.
Thank you, Mel. Hi everyone, I'm Natalie Schofield. I'm Head of Digital Data and Technology Programmes at West Yorkshire ICB, and I was asked to be involved in the integrated neighbourhood health work as the digital lead, supporting Mel and others in kind of moving forward in this agenda. I just want to go back to a comment that Leah made earlier, and one that I did hear through the engagement before we started on the work that we wanted to do around digital enablement. The key thing that I heard from the early days of starting on this work was that neighbourhood isn't anything new. It's actually something that's been in existence for a long time, and quite an established way of how communities have supported one another in their health and care needs. What has changed, however, is the complexity of kind of population needs and the complexity of services configured around that. And so how I approached kind of the digital enablement of the integrated neighbourhood health agenda was to really go back to the beginning and hear from the communities what would be the most impactful way of enabling them. And the key thing that I heard from a lot of our organisations was that they don't have the information they need really in front of them to be able to kind of provide the care or support they need to the citizen. So that's where the focus came from, and we went back to something that we already have in existence. So rather than reinventing something new, it was around how do we make sure that we're using the technology that we already have to better serve the needs of those that are delivering integrated neighbourhood health. And so whilst Mel mentioned that most of you will be aware of what the shared care record is, it's really a longitudinal record that sits above your clinical records, and it's a way that different organisations and professionals can access the most appropriate information relating to the individual in front of them. And I think in a complex multi-agency approach, I think appropriate is a really important point to call out, because I do think that citizens are interfacing with much more complex services now than they were before. So the longitudinal record needs to recognise that there needs to be not only health and care data sharing, but actually as across different organisations and the such. The Yorkshire and Humber Care Record is our strategic approach to that data sharing across services. primarily focused on sharing across our health organisations, but as part of the work that we're doing with integrated neighbourhood health, we're looking at how do we work in a much more multidisciplinary way to support data sharing across appropriate organisations. And we are on a journey, so you can see some of the kind of key areas of where data is being shared into the YHCR, as it's called. And we've worked with clinicians and frontline users to kind of identify what a really good minimum data set would be, and we're now on a bit of a journey to meeting what that minimum is, and also starting to identify some of the more impactful opportunities to enrich that data set that we have on the shared care record. So as part of the work that we were doing, we also recognise that there is a little bit more of an opportunity for us to think a bit more advanced in terms of how do we go the next step from just sharing the information, but actually how we develop and empower integrated ways of working across different organisations. And so the investment that we've got from West Yorkshire in terms of enriching this, the Yorkshire and Humber care record, is how we can invest in something called a digital shared care plan. So Mel helpfully referenced some of the work that's already going on under the Leeds care record in digitising respect forms. The work that we're doing on the YHCR is 100% a complement to the work that has been kind of trailblazed in Leeds in terms of digitising those records. And it's looking at the opportunities we might have to have an integrated digital care planning solution that will allow care professionals from multidisciplinary teams to develop read-write care plans, and the future ambition would absolutely be how we could include patients in on that journey and use the NHS app so that patients also would have access to their shared care plans. The aim is that this would be system-wide, so it'll be across health, social care, charity, voluntary sectors, organisations, but we're really at the beginning of some of this work, and hopefully the aim is that this will be live by the summertime this year. But we're already starting to work through what the kind of change programme requirements might mean in terms of changing the culture before the technology is brought on board. So as I say, the aim is to launch it around the summertime of this year, but we've already started quite a few workshops with our front end users just to start building those relationships and grounding the work really on the needs and the outcomes that are required from a place perspective. And some of the examples that we're seeing that we may want to focus our shared care plan capabilities on is around things like end of life and palliative care, or how we can support frailty or carers in our community. Recently, we also hosted a webinar where we brought examples of where this is already being done across the country. So we do have some really great examples from some colleagues in London, but also in Gloucestershire around the work that they've done in implemented digital shared care plans. And some of the statistics that are coming out of there are really they're really impressive, especially in terms of that end of life care planning and the number of patients that are having the ability to die in their place of choice. So I just want to kind of finish us on kind of where we're at now versus what the future opportunities are. What we've heard from many presentations today, and what we hear from a lot of our colleagues across West Yorkshire around some of the transformational and innovative capabilities that we're deploying around using AI to kind of predict where risk might sit or how we could remodel some of our care models. But we've got other things like our digital twin program, which is allowing us to have a shadow data set that we're able to look and model what risk might look like from a chronic kidney disease pathway perspective. There are lots of brilliant things that are already ongoing across West Yorkshire and wider in terms of the digital health agenda. From a West Yorkshire ICB digital function, right now our focus is still very much on the left-hand stream. So how do we create those consistent foundational digital and data capabilities that will really allow us to unlock the transformational and innovative capabilities that we're already seeing emerging, but also make the lives of individuals working on neighbourhood agenda a little bit more easy and a bit more efficient given the scale of work that we have to do. So things around what we're doing in terms of our improving digital literacy programme. So we've launched our DDAT literacy programme, and we're running webinars across the next 12 months that looks at building a digital ready workforce, and ensures that we're improving the digital capabilities of our colleagues. But also, Mel has mentioned around the digital inclusion agenda. We're doing a lot of work in terms of not only building the digital literacy of populations, but also how we build inclusive services. And we've got the Business Intelligence Consolidation Programme, which for the first time will provide a West Yorkshire-wide linked data set that will really allow us to unlock some of the and scale some of the capabilities that we've just heard Mel speak around, how we can deploy AI to think differently about that. So our primary focus right now is on those foundational capabilities and enabling the rest of the system to focus and unlock the transformational and innovative capabilities. And that's it from me, Mel. Thank you.
Fantastic. Thank you so much, Mel and Natalie. It was just brilliant to hear. It was great to hear about some of the kind of real world deployments of some of the AI tools, but to hear from you, Natalie, about how to get their foundations right so that, you know, that can then drive, you know, integrated working and enable the innovation. So thank you so much. We're a bit over, but we've got time for a bit of a panel discussion if speakers are happy to kind of join back in again. So can I ask Mel and Natalie, Anna and Mark to come back in and maybe put your cameras on while you're doing that. We've also got Amy Twyman from North East Lincolnshire, who's also working on the Neighbourhood Health agenda. And I've asked Amy just to kick us off with some of the kind of the challenges and opportunities she's experiencing in her work in kind of the Neighbourhood Health agenda. So I'll hand to you, Amy, and then we'll open up to the floor for questions for any of the panellists.
Thanks, Laura, and hello, everyone. Yeah, so I'm the digital lead for the Health and Care Partnership in North East Lincolnshire. So we have a slightly different setup in our place to a lot of others with relatively smaller organisations that are delivering health and care services. So we are as well one of the 43 places that are part of the national programme. Our clinical leads on the call as well, I noticed earlier, but we're part of the Humber and North Yorkshire ICB footprint. So as the sort of initiation of our neighbourhood health programme, we've been building on the existing work that we were doing around integrated neighbourhood teams. And I think Leah mentioned in her talk about the fact that that was one of their key considerations in who came forward to be part of the programme, was those existing relationships. So they're a really important part of how we work in North East Lincolnshire, that connection between our clinical services, our social care services and our VCSE sector. So that kind of formed the basis of how we were going to work as part of a neighbourhood health team. And then we've been looking at how digital can enable those clinicians and professionals to work together. So there's so many things that I'd written down are the same as the things that Natalie has talked through. So I'm conscious of time, I won't repeat it, but a lot of the same things. We have a great foundation of having a relatively high spread of a particular clinical system within our space. So that helps in terms of data sharing. We have data sharing agreements between our organisations, but it doesn't solve all of our challenges. There's always a bit of a wall once you step outside of the footprint of that system. And yes, the YHCR helps with some of that, but not all. We have some technical challenges with sharing data into there. And I think one of the key things that I was talking to Laura about that I know stood out to you, Laura, was when it comes to the collaboration tools that we have access to as the NHS, that brings with it some limitations. There are restrictions. So if we want to use and really utilise the Microsoft stack as well as possible, unfortunately, because of the kind of way that's been set up around guest access restrictions, it does cause us challenges with being able to share with our VCSE partners in ways that actually could be a lot smoother if we could really take advantage of that technology. We work in a virtual huddle at the moment as part of our initial phase 1 team. So that's been, again, building on our existing INT work, and we've been working closely with our BI teams in Humber and North Yorkshire to help identify those cohorts, which I think Hector mentioned earlier. We'd already started the process of looking and getting approval to do business process mapping. So as it has been said, we didn't want to do anything where we were just looking at digital in isolation. We want it to be built around how our neighbourhood health teams are working. So that was our plan. And then the expression of interest, again, that Leah mentioned came out. So we've put ourselves forward for that, keeping our fingers crossed that that'll help us to really understand how the digital tools lay over our ways of working. Similar challenges we have around demographics of our areas that were mentioned by Mark in his presentation, and that leads us to digital inclusion, which is another big area of focus for us. So yeah, and then actual physical neighbourhood health centres is something we're starting to look at now, and what kind of networking infrastructure we need to enable that, as well as the kind of systems that will be needed so that our community can access those services as smoothly as possible. So yeah, loads of things, but thank you for inviting me, Laura.
Thanks, Amy, and thanks for sharing those insights. That's just such a breadth of different things we could follow up, but it's really helpful to have that kind of overview. There's a couple of questions in the chat that I'll pick up, and then please do kind of raise hands if you'd like to ask a question. So I was going to ask about kind of patient and public involvement generally and how you're designing neighbourhood health. But Anna, I wondered if that slightly overlaps with the questions that have been asked in the chat about patient consent when there's an AI in the room, and how you navigate that, and what the response has been.
Yeah, I mean, so we had lots of patient engagement in how we were setting up our services right at the start. In terms of engagement, when we were then thinking about AI, I don't think we particularly did, but obviously the companies have been. And I think we were all taken aback by the patients being absolutely fine with us using it. We expected a lot more dissenting, which I mean, I haven't personally had anybody dissent from using it, which I think is quite remarkable.
I think that's absolutely fascinating, and I bet that speaks, tons to the way that you've talked to your patients and how they've been involved in it. So yeah, thank you. A second question, Natalie, to put you on the spot, is around the FDP and how that's been involved in the work that you're doing.
Thank you, Laura. So we are currently working with the National Federated Data Platform team, and we are deploying FDP capabilities in a lot of our trust organisations. The Business Intelligence Consolidation Programme, which is a mouthful, it's part of our readiness for adopting FDP. So we had quite a varying infrastructure across West Yorkshire in terms of our business intelligence capabilities. And what we're doing is bringing that together into a single cloud-based solution, working closely with our CSU. And what the vision is this will be our interim solution before we step into utilising the FDP as our primary source of business intelligence, and linking that up with kind of the system-wide work. So it's absolutely part of our roadmap, but there's a little bit of readiness that we need to do to get in order to get there.
Great, thanks, Natalie. So I'll now open up to the floor. Please either put in the chat or hands up if there's specific questions. A great opportunity to ask questions of our fantastic speakers. Brilliant. Tim, would you like to ask your question?
Yeah, thanks. You just saved me trying to type it, so it'll be easier to ask it. Yeah, thanks. Tim Fielding. I'm Deputy Director of Public Health in Leeds, and really interested in this field. Great to hear it. I've had to dip in and out a little bit so far, so apologies if I've missed some of it. It's about, and I know you've touched on the inequalities issue already and given some quite reassuring input. It's about the predictive AI tools that are already being used. We've heard some really good examples. I'm sort of on the margins of involvement in some of those in Leeds. But my understanding is still that those predictive modelling tools and those predictive case finding tools at the minute are still based on service use. So they're either based on individuals having a certain sort of minimum number of data points in their data. So they've attended GPs, etc., at least 10 times to have a certain amount of minimum data points, or they're modelled on a whole data set of service data. And I guess the question is, how do you avoid, because both of those are inherently drive inequalities, because we know people that are more disadvantaged have less access to healthcare, and certain people that are most in need on an objective level will have less access to healthcare or be in less contact with it at some point. So either they won't have the number of data points, they'll be excluded, or, for example, you might have certain ethnic minority groups that have very high health needs but have lower levels of health use, so that the modelling won't identify them as having such great needs if you're basing need on service access and service use. And I just wondered how we're taken that into account in terms of some of this to not be inherently designing in inequalities.
You'd like to talk to that, AC?
Thanks, Laura. I thought I'll have a go at this because this is a challenge across any sort of predictive modeling around AI, and specifically is worsened once you don't know what that black box model is actually modeling. So, especially for non-explainable AI-based data sets. So I think we would have because across any public sector organization, specifically across NHS, data often is unstructured, unclean, and then there is lots of gaps within that data, though that would exist. Quite a few organizations across the globe are taking an incremental and iterative approach while benefiting the population base so I think you'll see in the examples later in the day. I mentioned, again, I'm following the Brave AI sort of journey as an example in which, based on the data that exists, how you can profile and improve waiting lists for populations that benefit from it. However, you're right, absolutely, we need to keep an eye on how that perhaps worsens health inequalities as the data might not be incomplete. So looking at EDI data regularly, reviewing across sort of various forums and integrated neighborhood teams, using business intelligence in itself to highlight those gaps. Also looking at where digital access itself, due to digital poverty, it creates further challenges, would be an ongoing measure. However, I think we should look that as an opportunity and a challenge in the same breath, because of course we don't want to stop the progress that we can make to improve outcomes for patients that are already in the system and waiting for a long time. And specifically, if you think about the patient story at the start of the session, we don't want to necessarily stop that happening. But that is a challenge, that is an acknowledged challenge, and quite a few parts of the AI ecosystem around research and computing are working to improve algorithms and ways in which we can mitigate some of those challenges. So there is not a clear answer as it stands, but I think we have to collectively work as a system to bring those aspects to the decision-making bodies within places and come up with mitigations while the systems in it themselves evolve. Hopefully that gives you a bit of indication. I don't know, this is not completely the answer that you're looking for, but if you look at the Hippocratic AI example that I shared earlier in the US, how they are, so it's trying to be true to the Hippocratic Oath, and effectively as they're training the models, they are taking a very guarded approach. And I think there are such organizations that and AI modeling that's being conscious of those challenges, but it should not stop us or slow us down in terms of the benefits that we can provide as outcomes to existing service users.
Thanks, AC. Mel.
I mean, Tim, we haven't cracked, some of those issues that you've highlighted. That is something for us to work on as a sector. But what I would say in Wakefield, our BI data warehouse isn't just about episodes of care recording people who are accessing our hospitals and some of our service areas. We've got VCSE data in our BI data warehouse. We've got public health data. We've got adult social care data, which obviously is sometimes predicated by service user. So do take that point. But we've also got children's social care data. We're pulling on general practice use. So that is about episodes of care. But having that sort of full use of data within the system allows us to do the predictive IA tool and test it out. And we've only been doing it, I think it's 9 months, haven't we, Natalie? So we've still got a lot to learn on this. But I will say it's very challenging to include VCSE data in your data warehouses. A lot of work to do on that. And it took us a long time to start flowing things like Age UK data into our data warehouse. So, that is like a gold standard, I think, that people need to aim at, but there might be some more basic steps that people want to put in place first, because of the nature of how challenging it can be to get the DQ on some of the data flows for the VCSE sector.
Thanks, Mel and Natalie.
Thank you, Laura. It's just such an excellent question, Tim. I couldn't resist having a go at answering it. And I think it's so as we know, AI is only as good as the data it's pointed at. So I think and it's absolutely wider than just an AI question. I think we talk and focus a lot around digital inclusion, and I talk a little bit more around data inclusion and around how we need to think a little bit differently around how we collect our information, especially as we move towards data-driven decision making, given that, as you say, it can sometimes unintendedly skew decision making if we're only looking at kind of episodic care as one way. I think the way that pragmatically we're approaching that is, as I mentioned, we've got our business intelligence programme of work. Alongside of that, we're developing a robust West Yorkshire wide data strategy, and data inclusion is a fundamental part of that.
Final comment from Tim, and then I'll draw this section to a close. Tim.
Yeah, sorry, no one else had a hand up. I thought I'd be cheeky and just try and come back in. Really appreciate comments, and yeah, I certainly don't want to sound like I'm a skeptic or pessimist about it all. It's the direction of travel. It's the way to go. I absolutely get that, and it is encouraging that it's on there. I guess it's the things I suppose I'd be really keen to see working in this area is equity by design, where every approach we take to any AI and digital thing, it's not in as a sort of an assumption or anything, but it is absolutely design principle. My concern is if you don't design these factors in, they become a bit secondary, and it's default sort of average population first, inequality second. And the second bit is about having that because of the amount we know we don't know, and the amount of uncertainty about inequalities, and almost a likelihood is they will be there until we're a lot further down the line, that building in that triangulation between what the outputs of the digital AI predictive tools are and what we know through other sources of needs analysis, health needs analysis, that would tell us where we think those cases we would expect them to do that triangulation and sense checking, really, I suppose. And to keep checking. And the last one would be where we are taking those things. And I think you touched on it in your first response about actually, as these models get more advanced, we're less able to scrutinize and understand the way they're working and how they're actually coming to their conclusions, which is amazing, but quite concerning as well. So all our governance and assurance mechanisms need to be kind of take that into account. So, and actually, when we look at some of the data and the case studies, some of the very upstream data sets that these amazing looking tools are modeled on actually aren't representatives themselves. They might be based on a data set of white middle-aged men in North America somewhere. So actually we do find biases in them. And I guess it's having that high level of scrutiny and skepticism and curiosity about those things, while also not being, skeptical about the direction of travel overall would be my plea for it all. Thanks.
Thanks, Tim. You make such a valid point around, what is the data that's fed the models, and are we skeptical and curious enough to really delve into what's made them up? And I love your point about, can we design these equity by design rather than as the afterthought? I'm going to bring us to a close. I do want to offer people a short comfort break. At 20 past, we are going to start again, and we've got several fantastic innovators who will address many of the kind of the issues I think we've been talking about. We will hear from Brave AI. So they include Holly Health, Key Active, Enrich My Care, AbTrace, Brave AI, and Joy App. So thank you for the first half. We'll take a very short break and be back at 20 past, if that's okay. Thank you.